Good evening, sir. You're muted, sir. Sir, you're muted.
Yeah.
We are online now. Welcome, Hrishikesh sir. Namaskar.
Hi, I'm just trying to look for the presentation. Just give me 2 minutes. है ना?
Yes, sir. So you can look. We will start with the pleasantries.
Yeah.
Okay.
Yeah.
So, welcome to this 37th edition of the Searchlight series. And this time, the update is on the infertile couple. It is an association with Cancer Prevention and Relief Society. Now, I would like to introduce my convener, Dr. Sujayasri. She is the secretary of Bhimavaram Obstetric Gynec Society. She is consultant obstetrician and laparoscopic surgeon at Sheshadri Hospital, Palakol and Malkapuram. She is the founder secretary of Bhimavaram Obstetric Gynec Society. Is very interested in laparoscopy and infertility. She has started her own IVF center now and has many papers and poster presentations, does a lot of community work. So welcome, Dr. Sujayasri. I would also like to introduce my coordinator, Dr. Purvi. She's an executive member of Society of Fetal Medicine. She's been helping me along these webinars. She is a fetal medicine specialist trained under Dr. Adinarayan Makam. Past IFS executive member, IOTA and FMF certified. She's trained in fetal procedures, has many national and international publications. She is also a training faculty for ultrasound at my hospital. Welcome, Dr. Purvi. And now may I have the prayer, please? And then you may introduce me. I would like to invite everyone to join for the prayer. Have you shared the sound? Purvi, you haven't shared the sound. Would you please stop sharing?
Okay, ma'am.
We join hands for the prayer.
Ma'am, please open it with PowerPoint. On the right-hand side, ma'am. Right-hand side, top, please open it with PowerPoint. Yes, ma'am. And now please share the PowerPoint screen.
Can you see it?
Ma'am, you need to stop sharing this preview and start sharing PowerPoint, ma'am.
Can you see it?
Not yet, ma'am.
Over to you, Sujay.
Yeah. So I would like to introduce our program coordinator, who actually needs no introduction. So her current office, she's not made the correction yet. She's currently the chairperson elect for Committee of Medical Surgical Equipment, Food, Drug and Medical Surgical Equipment. Thank you. I would like to thank everyone who supported us in our endeavor. Moving on, she's currently the director of SMSA. Ma'am, could you please share the slide?
Yeah, just let it be. Let it be.
That's enough of an introduction.
So now I would like to introduce our speaker, respected Dr. Hrishikesh Pai sir, who is the immediate past president of FOXI. He has an extremely decorated CV. He was the president of FOXI in the term before this. He's the regional trustee, Asia Oceania, FIGO International Federation of Gynecology and Obstetrics, as well as Group Society License FIGO Women's Cancer Committee. He is the medical director of Bloom IVF with 11 IVF centers spread across India. He is the steering committee member for WHO Global Summit on PPH and subcommittee co-lead for Innovation Equity Forum floated by Bill and Melinda Gates and National Institute of Health, NIH USA. He's been the past president of Indian Association of Gynec, properly called the IAG, with membership of 5,000 plus members, past president of ESAR, founder chair of American Society for Reproductive Medicine, on the board of directors of IFFS, International Federation of Fertility Society, for 9 years. He has many awards, FRCOG fellowship, addendum from Royal College of Obstetrics and Gynae in the year 2019. He's delivered 41 plus orations, 700 plus lectures, edited 28 and more books, and has contributed so much to all of us. He is also a leader par excellence. And I would like to say he is a leader who likes to make leaders. So welcome, sir. I welcome you to this forum. And we are really honored to have you here with us. You are such a big name, I couldn't think of a chairperson for you. So we are here to listen to you with the audience. Thank you so much.
Thank you very much. I'll just try to share my screen.
Yes, sir.
Yeah, 1 second. एक मिनट जरा, let me just
I'm making you co-host, sir, so you would have less trouble.
yeah.
Any advance in ART, sir is the first one to adopt it and tell us about it. So the rocket science of infertility is what we are going to listen. Welcome, sir.
Okay. Okay, can you hear me?
Yes, sir.
Yeah, okay. So I'm going to basically talk about the future of ART. And if you don't hear me, tell me that because sometimes the signal. So I just go the slides. So as she was saying, I'm the trustee of FIGO for Asia Oceania, and basically FIGO has got one of them is the Asian region, second is the African region, third is the European region, fourth is the Latin American region, and the fifth is the American region. So in America, there is Canada, USA, and Mexico. So these are the 5 regions, and there are 5 trustees, and then of course there's a president, then the vice president, secretary general, treasurer, and there is a CEO also of FIGO. So these are the 10 people. In fact, day after tomorrow, I'm going for the trustee board meeting. The office is in UK, in London. So that's where we go for a meeting every year. So all because of you, without you, all I would not have been president of FOXI, and without being president of FOXI, I would not have been the FIGO trustee. So I am really obliged to you all for whatever I am today. So if you look at the standardization of care. There is an article in the Fertility Sterility by Knudsen et al. In 2022 about what do the common practice among consistently highly performing IVF programs in United States. A 10-year update. So they had done the survey of 10 years back, and now after 10 years, they did the survey again. And this survey was carried out on the 13 IVF programs, the top IVF programs of the United States, performing at least 100 cycles a year and having a cumulative singleton delivery rate for 2 years. Very high. So the topmost units were studied and they were questioned. So although directly not comparable, the singleton live birth rate among study participants in 2016-17 compared to the 10 years before, there was an approximately 25% increase in the singleton live birth rate per cycle for women less than 35. So in 10 years back, they were at 35%, but now most of the American units, they transfer single embryos. So that has gone to 60%. And there has been an 18% increase over between 35 and 37. So what are the practices? Because I wanted you all to know what are the standardization in the practice. So all the 13 clinics that were surveyed there asked various questions. And these questions answers I have shown you here. And the thing in green where I've said yes is the thing that I also do in my unit. So one of my unit is one of the highly performing units. We don't have too much turnover. Once upon a time, I used to do in Lilavati 100 to 120 cycles a month. But now me and Nandita together, we do about 40-45 cycles. Obviously, that time we were only 10 IVF centers in India, and now there are 3,000 centers. But our results are very high level results because, in fact, as the number of cycles has gone down, the quality has increased. So I always feel that quality and quantity are inversely proportional. If you have got lot of quantity, then obviously quality is going to suffer. So what do the high performing unit do? So most of them take eggs from the patient if they are less than 45 years of age. So 45 is the cutoff. After 45, many units will go for egg donation. Most of them will do ovarian reserve testing like AMH and LH, FSH. Then BMI, most of them cutoff is 40. If there's more than 40, they'll try to reduce the BMI to less than 40. Lifestyle management is done. Tubal status care is assessed by HHE. Uterine cavity is assessed by 3D ultrasound and hysteroscopy. Most of the people who have poor reserve, they are given CoQ, acupuncture, testosterone, DHES, growth hormone. And then the people who are PCOS, they are given metformin. They are asked to do weight loss. Some of them are offered acupuncture. And many people, they give myoinositol and coenzyme Q. And most people do mock KT prior to in the previous cycle. So when you're doing people, you can use a proper ET catheter and actually do a mock ET and map the uterus. But in my unit, we have not been doing mock ET. So I do all those things that these people do, except one, that is the mock ET. And maybe I was telling my girls that we should maybe start doing it. It's never too late to change and learn. So the second thing that you do is standardization has led to increase in pregnancy rate. So you can see in clinical practice, what do they do? They give OC pill prior to stimulation. They stimulate with FSH, LH and antagonist. And before trigger, the progesterone level is done to see the cutoff. If it is less than 1.5, then only fresh embryo transfer is done. If it is more than 1.5, then the frozen transfer is done. And if there is an endometrium less than 7 or in AMH, in my unit, AMH has to be less than 3.5. If it is more than 3.5, that means she is a hyper responder and we never do fresh transfers. Frozen transfer is done when the endometrium is more than 7. Luteal support is given with injectable. So now this is another difference. Most of the American units, they give injection progesterone for 14 days as luteal support. And a lot of studies have shown that if you give injectable progesterone, the pregnancy rate is higher than if you give vaginal. But in my unit, we don't do that because patient will run away. They'll not come for the second cycle. So what we do is we give every third day, we give progesterone injection. So what we do is 2 days we give vaginal and then third day we give injectable. Ultrasound for embryo transfer is done and ambulation is done by everyone. Within 5-10 minutes, they are sent home. Many of the American units, they send them from the table only. And ERA is done for RIF only. Some of the units are doing ERA, not all of them. In our group, we don't do ERA. So as far as if you see this slide, I do almost everything what they do, except that I don't give injectable progesterone daily for 14 days because I feel that's not fair for the patient also. And ERA is not, I don't do ERA unless the patient insists for a ERA. Then look at the lab. The lab practices, almost everything what they do, I do, except I don't have an isolate. So we use ultraviolet light to sterilize the lab, but never use it during the working hours. I only use the ultraviolet light during the weekends because the ozone is created, which can be toxic to the embryo. I do positive air pressure. Then I do HEPA filter, volatile organic compound filtration is done by filtration system. Humidifier is there, laminar flow hood is there, microscope heated stage is there. We off gas the plastic. Means what we do is we open the plasticware outside the lab because there is a gas that is trapped in the plasticware. So that may be ethylene oxide gas. So we always off gas the plastics and we use filtered gases. What about other lab practices? Yes, we use a benchtop incubator. We also use box incubators. That is, a large incubators are called box incubators. We use embryoscope also to do the thing. And then triple gas mixture is done where we use 5590 mixture, because the oxygen content nowadays we reduce to improve the pregnancy rate. Then a lot of people use single. So if you look at the American unit, 30% use single step media, 30% use single step media, which is replenished. Means on day 3, they change the media, even though it's single step, and 30% use a sequential media. Like in our group, we still use the sequential media. Sometimes my embryologists use a single step media, but we do ICSI for all in our group. But in American groups, 30% do ICSI for all, 70% do IVF or ICSI based on the indication. And ICSI only for male factor is done by 30%, which I do ICSI for all, and ICSI only for male factor, cryopreserved sperm or unexplained infertility or PGT, that is done in 30%. So the American units, they divide into 3 groups: ICSI for all, ICSI only for male factor, and ICSI only for male plus cryopreserved sperm plus unexplained infertility plus patients who are undergoing PGT. So different groups have got a different practice. What about blastocyst culture? Most of the units are using blastocyst culture, but they don't do sequential. In our group, we do sequential transfer a lot. I get a lot of patients who are failure patients, and I do sequential transfer with good results. The other day, one of my colleagues, Asha Bakshi, was saying that I've seen Dr. Pai doing sequential transfer, and I started doing it, and it really gives good results. So I felt really good about it. So then, of course, hatching for recurrent IVF failures is done for biopsy, for thick zona, for thawed embryos. Most units, American unit do it, and I also do it. Blastocyst transfer is done by most units. Single transfer. See, most of the people do in America single transfer, because if you do a double transfer, then if there's a twin pregnancy and if they are preterm births, then there's a lot of money spent in the incubator and complications are also there. So most people, they don't like to do double transfer. But in our country, like I am still doing double transfer only in those patients who have already had a child with me before. For example, yesterday I did 2 patients. One had a child with me 6 years back. She was from USA. She had come for a second transfer with a frozen embryo. And one person had a child with me 10 years back. So it's fun now because we have got embryos frozen for nearly 25 years. So we have a lot of people who come back after many years gap. What about vitrification of blastocysts? So we do vitrification of many people, they collapse the blastocyst, because if you don't collapse the blastocyst, the outcome may be not that great. So, but in our group, we vitrify on day 3, and then we thaw the embryos and culture them to day 5, make the blastocyst and then transfer, because we feel that vitrification of day 3 blastocyst is much more easier. With the if you try to vitrify blastocyst, there's a cavity and the ice crystal formation will be higher with those patients. So in my group, we vitrify on day 3, then we'll thaw them and culture them and then transfer a blastocyst on day 5. What about PGTA? So most of the groups in USA, if the patient is more than 38 years of old age, they offer PGTA. But we don't offer. For RIF, we they offer and we also offer. And for the RPL also, we can offer PGTA, especially if it is two failures. What about PGTA? What does it do? Does it increase? Yes. So there's an increased number of single transfer, because once if you put a tested embryo into the cavity, the pregnancy rate, the live birth rate is as high as 60% in many centers. So many people in USA and China, they try to do PGT in the first attempt itself. But in India, we can't, we are not allowed to do it. So we have an indication under ERT bill. And of course, it decreases the time to pregnancy, decreases the miscarriage rate, etc. And most labs are doing key performance indicators. So what is KPI? So you can have a IVF fertilization rate, ICSI fertilization rate, ICSI egg degeneration rate, day 5 embryo quality rate, day 6 embryo quality rate. So all these are KPIs. So all our labs, we maintain KPI to see that our pregnancy rates are maintained over the months. Every month the KPI is plotted and we can decide whether our lab is performing well or not. Now with the all these IVF, there's a growth in the other services as well. We have more in many people in IVF have mental issues, so we have counseling services. Many of us have started buying 3D ultrasound. We do most of my patients. I do 3D ultrasound now. I don't do 2D ultrasound because it can pick up septum, polyp, a small fibroid which is sitting near the lining. You have sonovac ultrasound, means automatic. You can do the follicle study by sonovac ultrasound. Then we have endoscopic surgeries. Then we have PRP and stem cell services, high risk pregnancy management, NICU and PICU services, and genetic services as well. So all these things are available with our units here. 1 minute, hold on. So these are the services that are available because of the IVF. So there's a boom in other services that are there. And then, of course, regulation and compliance has accelerated growth also, because we all were worried that we'll have the surrogacy bill and the ART bill. But in fact, there are a lot of advantages of regulation. There's an increase in ethical and safety standard. Trained personnel and good equipment are now available. Because we have to follow the regulations. Affordable and accessible care is there. Transparency and accountability is there, record keeping is there, and all this will minimize malpractice. If you have proper record keeping, if you do a proper protocol, obviously medical legal malpractice suites are going to be lesser. You protect the rights of the donors and surrogates. Clarity is there in legal resource. I've got my lawyers now. Everything I do with the lawyers. Of course, thoda cost has increased, but what can we do? What are the disadvantages? Increase in the cost. It can be offset by governmental intervention. Then criminalization, punishment should be decriminalized. I feel that there is a punishment in our ERT bill which we should be decriminalized. There should be fines rather than imprisonment. And we all should go to the government next year. After I'm a bit distracted now, but next year I'm planning to go to the government and try to do these changes. Of course, not alone, but with all of you and with all your strength. And preventing donor compensation can be replaced by supervised loss of manna. So, for example, in England, if you are a donor, you get 750 pounds. It's a fixed amount, fixed by the government of Britain. So, similarly, we can fix an amount, maybe 10,000 rupees or something, which is like a compensation for the manna's loss, because that is not there in the law. So, we'll have to request the government to add that to the law. Minimizing complications has improved consumer confidence. So we must modify our COS protocol. So in our group, when I was initially in the olden days, 15 years back, I used to do GnRH agonist long protocol. And after that, I shifted to the antagonist protocol. And let me tell you that my pregnancy rate fell by 5 to 7%. I had the highest pregnancy rate when I used to use the GnRH long protocol. But I had a lot of hyperstimulation. And, I said, I was so happy now when the antagonist cycle came in. And now whenever you have a problem, you can give a GnRH trigger and freeze all the embryos and then transfer them in the next cycle. That is called segmentation. So I don't mind having a lesser pregnancy rate, but safety is very important. Even if one patient dies due to the pickup or there is some problem, then it can really set you back in your practice as well. So there's of course advancement of oocyte retrieval techniques also that has minimized complication. Transvaginal ultrasound has come in a big way. Now, if you look at the WHO infertility prevalence estimate, so this was a study conducted by WHO in last year, and there were 12,241 studies that were scanned by the WHO group, and out of that, 133 studies were singled out, and they found that the prevalence of infertility was 17.5%. So it's a big problem. In the olden days, we used to say infertility is 5% to 10%, but it was all vague. Now, because of this WHO document that has been published in 2023 last year, now the governments of various countries can put the IVF program as a part of their national policy, because you can't put it unless it's there. Okay, there is a lot of prevalence. 17% are having infertility. So governments can start compensating patients through national programs like Ayushman Bharat, etc. So, but there's a lot of countries where one IVF cycle cost is more than the average annual income of a lot of people. So IVF can push people into what is known as health poverty. And so governments will have to find out what is the way in order to overcome this health poverty. So we can have advocacy, we can have public financing, like we in KM Hospital, from where I was the houseman and registered to Dr. Indira Hinduja, who did the first IVF baby. In 1985, I was a houseman, and we all celebrated the first baby. I remember I went to her house and we had a party in the night when the first baby, Harsha, was delivered. And madam took us all to her house for a party in the evening. So then, of course, Lucknow, there was Dr. Singh, who had a fantastic program. Unfortunately, was no more. And the MP government has subsidized IVF cycles, CGHS, AIMS, and now Maharashtra government is also started putting up IVF units. So there are a lot of, then we can of course do competitive pricing is there in private sector. You get now EMIs, interest-free loans, you can get insurance cover is also increasing. So all these things are going to contribute to the access of IVF to people who are not that well off. Ethical clarity has increased utilization of services. So now egg donation, surrogacy, we have more clarity how to do it in India. We can't do it commercially. So we have to be altruistic in our approach, both for the egg donation and surrogacy. And now recently, a lot of licenses have been started being granted under surrogacy also. So we slowly will go back to a normal, because these are two important services that are important for a lot of infertile couples to achieve pregnancy. Medical tourism is propelling our country as well. So we have different types of tourism. We have one is what is called intra-country tourism. So in intra-country tourism, you may have an intra-city tourism. So one part of, let's say Indore, one patient doesn't get pregnant, she'll go to another part of the city. Or there may be intercity tourism. So one part of, this thing, 1 minute, hold on. Bharti, I'm in the Zoom, I'll talk to you, I'll come later. So one part of one city, suppose Bhopal, you are not become pregnant 2 times, you'll go to Indore and try for so the intercity tourism is there. And then inter-country tourism is there. So there are 3 types of inter-country tourism. One is the cross-border tourism. Means you have like Dubai, people, they can't do egg donation, though they come to India and do egg donation. For example, Indian people, if there's a difficulty in doing surrogacy for the second time, they can go to Croatia or Ukraine or United States or Greece or Bangkok to do surrogacy. So that's called cross-border tourism. The second tourism is cost-effective tourism. Means people from abroad, say UK person wants to do IVF in the private in UK, it costs 15,000 pounds. But he comes to India, he can do the same thing in 2,000 pounds. So because of the cost, he comes to India and does the IVF. And then there is the cost quality tourism. So the UK person is having NHS where he can go and do an IVF free of charge, but he comes to India because he says that no, Indians are better than the Britishers. So a lot of our Indian doctors have now become so highly skilled that many of them are better performers than people abroad. And that's why people have started coming to them. So India is a really becoming very, very powerful. And a lot of people over the next, I foresee that a lot of African patients, I get a lot of patients from African continent, and they look up to us also. They are comfortable in India. They feel that we are more equal to them, and we look at them with respect, and that there is no discrimination. And many of the people are coming to India for, and all of you who are having IVF units, all of you are going to see, all of us will become, will benefit from this. So, of course, awareness building has led to increase in demand. So, community outreach programs are there, TV and print media, digital media. So many of our, I see so many of our IVF specialists have got 1 million followers on YouTube and all that, in Instagram. And then there are the more, I got, you can become my Instagram. It is hrishikeshpai.com. I got for nearly 42,000 followers now. So the special media campaigns are also available. Like the IFFS has got what is known as the More Joy campaign. So International Federation of Fertility Society, our Dr. Rishma, our past president, she is now the treasurer of IFFS. IFFS has made all these posters and all. You can take free charge and put the Instagram. You can use it for your, if you go to the IFFS site, wonderful resources are available which you can take and you can use for your own marketing of your own program, promoting it in the community so that more and more IVF people come forth for IVF and you can service the patient that come to you. And then, of course, new areas keep popping up. So there are a lot of new areas that are there which keep on popping up. And some of the areas I'll just now touch. So in the sperm, for example, we have got a lot of areas. We have got, this is the automatic sperm analysis. So we have got this, I got two systems that are there. Here you can just take the sperm in the syringe and then you can just put it in the machine.
Inspect the capillary for the
You can put it in the machine. Yeah, 1 minute. I can just play it again.
next the sample priority.
So basically, you can see that you just take it, load it, and then automatically, and there's a cloud-based system. Automatically, it will give you 12 parameters. So it's very good. It's a very superb system, and this is very crucial because you send it to a normal lab. It may be having male factor, but it may wrongly count the sperms, and he may give you a normal report or morphology. He may normal count wrongly or motility. See, you can just put it in this, and it's very cheap. It's around 1.5 lakh rupees machine, and that cartridge, the syringe costs about 400 rupees to do. So 400-500 rupees. Only thing, it doesn't give you microscopy. So that you can do additional stainings. 1-2 drops of it you can send to a normal lab to see for microscopy, but rest of it automatically you can do it. There can also the sperm preparation. The olden days we had the double density gradient or the swim up, but now the microfluidics has come up. So in microfluidics is a very good technique where we have the cartridge. You open the cartridge and you load the semen, liquefy the semen, load the semen with in one of the chambers. Then there is a membrane between the two chambers. That membrane has got micro channels through which the sperm swim up into the chamber where the culture media is there. So you put the culture media in the next chamber at 37 degrees, and then after 20 minutes or so you harvest it. So first you load the semen. You can see it's in the lower chamber. The semen is being loaded. Then you load the culture media in the upper chamber. Just the flushing media. If you don't have CO2 incubator, you can use flushing media. If you have a CO2 incubator, you can use a bicarbonate media. So the two chambers are separated by a membrane which has got microfluidic channels, and the sperm will swim up in through the channels into the culture media. After 20 minutes, you take the culture media and put it in the cavity. So it's a very simple technique and superb result. The only thing, it is effective in all samples except samples with high DNA fragmentation. In that, microfluidics doesn't work. In that, it is better to use a double density gradient for patients with high DNA fragmentation. In all other patients, you can see beautiful sample on the macular chamber, how motile, densely motile the sperms are. And then, of course, you can also, we can do what is known as micro TC nowadays, in patients of non-obstructive azoospermia. You can use a microscope and do the biopsy of the some and do the. So in patients where we have not got sperms in the testicular biopsy, we get 50% of them, we get sperms in the micro TC. You can also do IMSI. So normally we do the ICSI at about high power magnification of 200 to 400 times magnification. But you can do IMSI at 6,600 times magnification. So you can actually find and you can measure the sperm head, the sperm tail, and you can see whether there is a vacuole. And with this, you can select better quality sperm and you can also give better performance, especially in patients with repeated IVF failure. You can also do what is known as artificial intelligence. Now, this is what is known as SID on the right-hand side. So when you are doing the ICSI, you are attaching it to a server in Mexico, and the server looks at the motility, morphology, and the tail movement, the head movement, and using artificial intelligence, it identifies the best sperm which you can immobilize, and so it gives it grade A, B, and C, and you can pick up the A grade sperms and you can inject them into the oocyte. Well, you can also do what is known as spindle check. So this is a technology where you can actually see the chromosome spindle. You can see this chromosome spindle that is there. So this technology, you can put the spindle at 12 o'clock position and then inject the sperm. And especially this technology is also used for egg freezing. So if you retrieve egg, want to freeze them, if you get the spindle formation, normally after the retrieval, spindle formation takes place in 2 to 3 hours time. So normally if you don't have 3 hours after the
So your voice is breaking a little.
spindle machine, because sometimes the spindle is delayed. Spindle formation and how the oocyte, the spindle reforms in 1 hour to 2 hours time. So if you wait for the spindle to reform and then do the ICSI procedure on a frozen thawed oocyte, you get better results. So that is why the spindle check machine, of course, it's very costly, cost 20-25 lakhs, but we have only one machine in our Lilavati lab, but I love the machine. It's a beautiful machine. So that, of course, you can also have another technology which is called what is sperm vitrification device. So with this technology, even 1 or 2 sperms, normally for freezing sperms, you need a lot of sperms. But here in this device, which is from Israel, you can even freeze 1 or 2 motile sperms. So many patients of non-obstructive azoospermia, they are actually having cryptospermia. I mean, if you take 10 samples, one of the sample may have 2-3 sperms on a centrifuge sample. So what we do in non-obstructive azoospermia, we give them gonadotropins, we give them anastrozole or clomiphene, depending on whether they are obese or not. And after that, after 2 months time, I call them to my unit and I do multiple samples. Every day I collect the sample and check for the sperm in the centrifuge sample. And sometimes if we get the sperm, we'll freeze them in the sperm vitrification device. So it's a superb. We have done so many patients who have failed with micro TISA or in testicular biopsy, they have not got sperm, but in multiple centrifugation of samples, we have collected sperms and given pregnancies to these patients. Of course, you can do also make the sperms out of stem cells, skin cells, and this technology is going to come in the future. As far as the oocytes are concerned, you can do oocyte freezing or ovarian tissue freezing for fertility preservation. As I told you, you can also do artificial intelligence. So when we are doing oocyte freezing, prior to that, what we do is we can assess the oocyte by doing the grading of the oocyte. We take the photograph of the oocyte and export it to the server in Canada. This program is called Violet, and based on the server, the server gives grading to the oocyte. And if the oocytes are good quality, then we can tell patient that we don't need to do first repeat cycle. If the oocytes are not that great, we can tell patient to do one more cycle of freezing. Another problem is the problem of poor ovarian reserve. So biggest problem, if she is less than 35 with a poor reserve, I always look for tuberculosis. I like to do an endoscopy, laparoscopy. I look for Fragile X syndrome and Turner mosaic by doing a karyotyping and a PCR. And I do stimulation. Prior to that, I give them DHEAS test. I give them growth hormone, multiple stimulations, pull the embryos, and many of these pair to that we can also do ovarian rejuvenation. In the olden days, I used to do transvaginal PRP, but I feel it is highly inaccurate technique because in patient with poor reserve, the ovaries are very small. If you do a transvaginal PRP, definitely you will put the PRP outside the ovary somewhere. So instead of that, it's better to do it under vision with using a very small thin needle. And nowadays, I also do what is known as stem cells. So we combine stem cells and PRP. I've just started doing it because now the new regulations have come from the government where you can use stem cells provided you don't manipulate the stem cells. So you should not touch the stem cell. You take out the stem cell, separate them, and immediately if you put them back, then you can do the stem cell injection and you will not have medical legal problem. There's another thing that is also coming in a big way. Many people are doing what is known as NAD IV drips. So you can give NAD, nicotinamide, adenine dinucleotide, IV, subcutaneous, oral, sublingual, transdermal patches. But most people take IV drip 100 to 500 milligram diluted and administered IV over 6 hours. And it helps in cellular regeneration and repair. And many people feel that poor ovarian reserve patient, they stimulate better with the gonadotropin. You can also do what is known as nuclear transfer. So in patients with mitochondrial disease, you can take out take a donor oocyte, enucleate it, and take the patient's nucleus and put it in the donor oocyte and create a new oocyte and then inject it. You can also do what is known as embryo selection. So what is new in the embryo? In embryo, the select techniques are very important because suppose we have 5 blastocysts and you want to put only one bag. How do you select the embryo? So one way to select them is by doing morphological analysis, which is the traditional. It's a very good technique based on pronuclear formation, cleavage embryos, rate of cleavage, symmetry, multinucleation, blastocyst, expansion, trophobectedom, inner cell mass, all these parameters at different stages of embryo development can be used to assess the embryos and grade them morphologically. But you can also do, if you want to be very accurate, you can do trophectoderm biopsy, what is known as PGTA. So you can take the biopsy from the outer cover, that is known as trophectoderm. Normally, the trophectoderm forms the placenta, and the inner cell mass is from where the baby is formed. So if you take 3 to 4 cells from the trophectoderm, you are not going to harm the baby in any way. Of course, there can be sometimes discordance. So trophectoderm may be abnormal, but the baby may be normal. So that's called mosaicism. So that's the problem with biopsies. You can, of course, do biopsy for various things. Like you can do it for single gene disorders like thalassemia, which is known as PGTM. You can do it for recurrent abortions, which is known as patient more than 35 years, 38 years of age, or patient with recurrent IVF failures, or patient with recurrent miscarriage, which is known as PGTA. Or you can combine all these 3 techniques of M, SR, and A, which is known as whole genome amplification, PGT, WGA. And finally, you can also nowadays select embryos for diabetes and hypertension and cardiac disease. This is a new technology. It is called PGT for polygenic disorders. And then, of course, you can do what is known as expanded carrier screening. So if a couple comes to you, they are married and they say, Dr. Pai, we want to find out whether we are having a problem. You can do a whole genome amplification and screen for both husband and wife. And based on that, you can see if there is any recessive gene in both of them. If there's a recessive gene in both of them, which can manifest in the embryo, then preventively you can offer them PGTA or amniocentesis in the first pregnancy itself. You can also do what is known as non-invasive chromosome screening. So instead of taking a biopsy of the trophectoderm, you can take the DNA that leaks around the blastocyst as it is growing in culture and amplify the DNA and then test the DNA using NGS, which is not as accurate as a biopsy technique, but now more and more, like in our unit, we are now getting nearly 85 to 90% accuracy. You can also do what is known as time-lapse imaging. So in this, you can take the video of the embryo as it is growing in the incubator every 15 minutes. And then this is exported to a server in Sweden where they can grade the embryos and tell you which is the best embryo for transfer. If you don't have very costly technology, you can do what is known as embryo ranking. So we have got this AI technology in our lab. It is known as Life Whisperer from Australia. So you can take the blastocyst photograph and export it to the server, and using the static image. Instead of using a video, you can use a static image and also grade the embryos and select the embryo for transfer. You can also do modification of the embryo. So if there is a, let's say, a thalassemia major embryo, you have done a PGTA and you found that the embryo is thalassemia major, you can correct the thalassemia gene by using a technique called CRISPR. So you can use the probes and you can correct the gene, and you can then, instead of throwing away the embryo, you can correct the embryo and use it for future pregnancies. But this technology is still experimental and they are not allowing the corrected embryos to be transferred back for actually clinical pregnancy. What about the endometrium? So there you can do what is known as ERA test, or you can do, there are a lot of people who have got endometritis. So you can take the biopsy, amplify the endometrium RNA, and then do the NGS and find out whether there is any infection in the endometrium. Of course, your thin endometrium, you can do a lot of things like hysteroscopy, you can give them GCSF, PRP, etc. Or you can even do stem cells in this patient. And finally, you can do surrogacy on this patient. Normally, surrogacy in a infertile couple, most of the infertile expert, they don't like the concept because, in this, you can, if the donor dies during the uterine transplant, then, there can be a problem for the doctor. So if suppose there's a kidney transplant and if the donor dies, it can be justified because you are doing a transplant for saving someone's life. But if a donor dies in a uterine transplant, it cannot be justified because you can always tell patient not to have a child, or they can have an adoption or whatever. So I feel that a live donor transplant is not ethically advisable, and that's why the uterine transplants are done in all over the world, but that they are not too many. But there was a breakthrough in that, in the form of what is known as cadaveric transplant. So nowadays in Brazil, the first cadaveric transplant was done. And so if for the cadaveric transplant is then it is justified, And of course, because of IVF, there's an increase in the parallel work. Asha, have I got time or should I shut it down? Hello?
Sir, you can take another 10 minutes. No
Asha?
issues. Yes, sir. You can take another 10 minutes.
Yeah. So there is, because of the IVF, there is increase in parallel work. So there are things like I told you, expanded carrier screening now. A lot of people in United States, and even here we are offering now. And it's not very costly. It costs 15,000 rupees. See, in the olden days, what used to happen? You used to have the first baby and that was affected. And then you said, "Arey, baapre, there is a problem." And then in the second, but then your life is finished because the first baby is affected already. Now you do the testing and screening right at the beginning. And if there are recessive genes in both husband and wife, then they can come together and manifest in the embryo. So you don't have to do PGT. You can even, if you have a carrier screening positive in both husband and wife, you can even offer them antenatal screening and abortion. If there's a, so it's not necessary to do a PGT because PGT is a much more higher level procedure. So we can do PGT for monogenic disorders like thalassemia. I told you, you can do it for polygenic disorders to rule out diabetes. So now there are what is known as polygenic references. So you can have multiple genes. So you can, using that analysis, you can find out whether that particular embryo is prone to diabetes, and you can select the embryo which is less prone to diabetes. So all these techniques have ovarian rejuvenation technique, fertility preservation, uterine transplant, biotechnology, all this has created a lot of increase in the parallel work. So IVF has spawned a huge amount of other parallel work. I told you ultrasound, endoscopy, etc., ICUs, pediatrics, because many of them are preterm birth. And if you look at the profitability, it is huge profitability is there. Regionally, if you can see that there is a nearly, there are 5 segments I told you. And if you see the global IVF market, it is at, in 2021, this study was done where it was at 23.6 billion. Europe is got the largest share of IVF at 36%. And that is because of rising medical tourism in Europe, legal visions and availability of reimbursements in almost all countries, and ongoing Ukraine war may stagnate the growth to some extent. In North America, there is an increase in demand for fertility treatment, standardization of procedure through automation, regulatory reforms are very many, government funding is there for egg and sperm storage, and the introduction of more IVF treatments are there by industry partners. But our Asian market is really going very strong, and a lot of things are contributing to that. Fertility tourism, increased foreign investment to penetrate economically developing countries, changing regulatory landscape. Incidence of infertility has increased due to changes in lifestyle, such as increased prevalence of obesity, stress, lack of exercise, improper eating habits, lack of nutrition, and rise in population, pollution, as well as due to prevalence of medical conditions such as diabetes. So all that has resulted in a increase. The Indian market of 1 billion US is there in 2024 and is supposed to grow to 5 billion by 2033. So in 10 years time, we are going to grow at a very rapid rate. Africa and Latin America are still lagging behind. So in conclusion, standardization of care has increased the pregnancy rate. I told you all the 13 IVF centers in USA, how they have standardized their care. So if you, I always every 2-3 months, I read that article just to see what is happening and stay in touch with that, what is happening in the American side, because Americans are very advanced in medicine. So there, even their pregnancy rates are the highest in the world at present. There is an increase in ancillary services. Regulation and compliance has consolidated the specialty. Minimizing complications has improved consumer confidence. Participation of NGOs and ministries of health has enabled health equity. More poor people can have access to IVF through hopefully through Ayushman Bharat. Ethical clarity has increased utilization of service. Medical tourism is propelling our economy. A lot of more people are going to come. India is a powerful country. More and more people are going to come to us. Of course, I had gone to China, and in China, they are 10 times larger than our country, as far as IVF is concerned. But there is no access to other people in China. See, an African can't go to China, but an African can come to India. So ultimately, we are going to pick up as our infrastructure increases, our roads become better. They should not come to India and get dengue, malaria, and fall sick, or get diarrhea, or get mugged by someone. So these are all important things. If once our country becomes better and better in infrastructure, obviously other things like medical tourism are going to go up. Awareness has led to increase in demand and increase in supply. Awareness, availability, advocacy, affordability has improved access. New indications, innovation, and research will contribute to success. Improving profitability has attracted investment and growth. Many new chains are coming up. Hospitals are becoming more regularized. More access is there. More people are accessing the services. And yes, ladies and gentlemen, the future of IVF is very bright. You can see Dr. Nandita, Dr. Rishma, Dr. Bob Edwards, and Dr. Yuri Verlinsky, one of the biggest geneticists in the world. He had done 150,000 amniocentesis. He was in Chicago. They are all no more now. The two on the right are no more, and the three on the left are all now slowly becoming older and wiser. So thank you very much for a patient hearing. And I hope I have given you a big perspective about IVF.
Thank you, sir. Thank you. Ashish, sir, would you like to say something here?
No, as usual, sir, it's a insights of IVF journey and the future of IVF. Always, it's a things to listen, because you always come up with the new things first in India and our country. So there is always a first thing with your name, and we are really delighted to hear from you, sir.
Thank you, Pai, sir. Actually, I had kept your talk third because
our upcoming patta.
No,
So before I leave now,
Yes,
all
sir.
of you have to come. There is a fusion conference in Jaipur now in between 13th to 15th, and the All India conference is there. You all have to come for the All India. We are making a lot of preparations, and we'll give you a very good time. 2013, there were 12,000 people that time, of course, and hopefully this time also we'll be able to try and take care of you. Our hospitality is there, and we all love you, and we are waiting for you to come. And what I've also done is I'm going to offer now, so accommodation, normally you have single room or you have twin sharing, right? But
Yes.
single or double occupancy, but we are now going to offer twin sharing. So even if you have, suppose you have no one with you, if you send, then we'll match you with someone and we'll halve your price, because in Bombay, the room prices are, some of the hotels are at 23,000. But if we put you on twin sharing, it will go to 12,000. So 3 days, 12,000 is not that costly. So that's how we should reduce the cost so that all of us can come. And then if you go to little away, say half an hour away, hotel will be available for 10,000. But if two people stay in the room, your accommodation will be for only 5,000. So that makes a difference because half an hour is not a big amount. So that you can just take a Uber and come, and the AI switch is going on for the whole day. You can come aram say at 10:30, 11, and then stay till the 9, 10, 12, till Sonu Gemam song is over, and then go back. So that is how you have to. So because one thing what I want to tell everyone, it is our conference, and we should stop relying on others and do it ourselves for from our pockets, and we should all enjoy our fellowship. Before I leave, I'll tell you one more caller. Ambani wedding ko bulaya main and Rishma. We went to the Ambani wedding, and there were 14,000 people, and I knew only 100 because maybe some people knew me, but I didn't know anyone much. Then when I came back, I realized that I am a nobody. Miss outside my little pond of Foxy and MOGS and ISAR, I'm nobody. So it's what I realized, that's importance of our association. See, within our association, within our profession, we have a standing, we have friendship, we have respect, we have fellowship. So we must value that very much because outside we are not bothered. People don't bother. They may say, "Ha, doctors are there." They are not bothered. So remember, you must always value your association, whether it be IMA, Indian Menopause Society, ISOPAP, ISAR. You take whatever association and you put your heart and soul into it and enjoy that association so that you are happy about it. Thank you.
Thank you so much, sir. Thank you. Anuradha, would you like to say something?
No, ma'am, it was very good, very informative and new initiative in the matter of sperm in a non-ostotic azoospermia. It is very informative, ma'am. Thank you, ma'am.
Thank you so much, Rishi sir. It's time other people would be getting desperate for you. So, Dr. Ashish, you want to go first or you want to go last?
Madam, I will go last.
Okay, so then I would this is a new system I have, and I'm having a great problem setting everything up. Can you see my slides?
Yes, ma'am.
You can see the slides?
We could see, ma'am, that time. Now it is not seen.
Okay, Microsoft PowerPoint share.
Yes, ma'am. Now it is visible.
Okay, so now I would like to introduce Sonal Panchal, ma'am. Purvi, would you want to introduce?
Yes, ma'am.
She is my teacher of ultrasound. So please do the honors.
Yes, ma'am. For our next talk, we have Dr. Sonal Panchal, ma'am. Ma'am practically needs no introduction. She is a consultant at Dr. Nagori's Institute of Infertility and IVF, Ahmedabad, India. She has PhD in ultrasound and gynecology and infertility, Master Ultrasound in OBGYN, Iron Donald Inter-University School of Medical Ultrasound, Professor in Dubrovnik International University, National Academic Director of Iron Donald School, India, Director, Center of Excellence, Iron Donald Inter-University School of Medical Ultrasound, Ahmedabad, National Advisory Board Member for International Journal of Infertility and Fetal Medicine, Reviewer of Journal of Human Reproductive Sciences, published 45 papers in national and international journals, delivered more than 800 lectures, contributed and authored several books, more than 120 chapters. She has keen interest in infertility, gynec ultrasound, 3D, 4D ultrasound. Ma'am, you're muted.
So I would like to share Madam's presentation and we can take it forward from there. Just let me know if you can hear.
Good evening, friends.
Yes,
At
ma'am.
the
we can
onset,
hear.
I'm very thankful to Dr. Asha Jain for this opportunity and welcome to Searchlight on behalf of the entire team. My topic today is role of ultrasound in infertility. To establish that the reproductive organs are normal, if there is a lesion, is it pathological or physiological? If it is physiological, is it concurrent with the phase of the cycle? If it is pathological, will it come in the way of fertility? And if so, does it require prior treatment? These are the questions which need to be answered, and that's why we do an ultrasound as a primary investigation for all the patients presenting with infertility. But it's essential to do this scan very systematically. Start observing the image the moment your probe is on the introitus. Look at the pubic symphysis, the urethra, the bladder, the vagina, the interior wall, the posterior wall, and the rectum posteriorly, and gently insert the probe. Ideally, the uterus must be seen in the mid-sagittal plane. As you introduce the probe, your probe is right in the midline, and it should show the uterus in the midline. If not so, which means that the uterus may be either deviated or twisted and would indicate possibility of abnormalities. Having located the uterus in the mid position, that is when the measurements are taken for the uterine length as well as for the endometrial length. Evaluate the cervix, the fundus, and the body of the uterus, and also the shape of the endometrium. Having done that, one has to span from one side of the uterus to the other side of the uterus in the same longitudinal plane to rule out any abnormalities in the uterus, and then rotate the probe 90-degree anticlockwise for the transverse section. Go towards the fundus to look at both the cornu and go towards the cervix to look at the normalcy of the cervix, and also to rule out any possibility of abnormalities of the uterus even in the transverse section. This will allow you to decide the orientation of the uterus, and the orientation of the uterus can be anteverted, anteflex when the cervix from external os to internal os is progressing anteriorly, and the body of the uterus is also progressing anteriorly. When I say that, it's very important to understand here that the probe always has to be in a consistent direction where the marker of the probes are always facing the roof. And if they're facing the roof, that means the entire aspect of the patient. In all these cases, you would, with the image oriented in such a way that there's a logo on this corner of the image, that means that this is the anterior aspect of the patient, this is the posterior aspect of the patient, because the logo correlates with the marker on the probe. That means if the image position, if the image orientation is not changed, this is always an anteverted anteflex uterus, and this is always a retroverted retroflex uterus, where the uterus from the anterior aspect of the patient, the cervix external os from the anterior aspect of the patient is progressing posteriorly towards the internal os, and the body of the uterus is also facing posteriorly. Whereas this is a anteverted retroflexed uterus, and this is a retroverted retroflexed uterus. This is a retroverted anteflexed uterus. So that is those are the different orientations of the uterus which must be taken care of, which must be always documented on all your scans. To just re-emphasize, you can see the logo here. And when you see that logo, if I said that it corresponds with the marker on the probe, and the marker on the probe is on the anterior aspect of the patient, that means this, which is the footprint of the probe, and this is the logo. So this is the anterior aspect of the patient, that is the posterior aspect of the patient. This is the caudal end, and that is the cephalic end of the patient. So that is about the orientation of the image and orientation of the uterus. And this is to be maintained consistently to avoid any confusions about the anterior, posterior, right, left. Once the uterus is located and is examined, thoroughly well on the longitudinal and the transverse sections, that's when we are going to look for the entire pelvis to evaluate whether there are any uterine abnormalities, ovarian abnormalities, tubal pathologies. Tubal patency is also to be assessed before the treatment, and that's what ultrasound can do. And of course, also to assess the ovarian reserve and the response. These are all the pre-treatment assessments. Of course, the ultrasound is not useful only for the pre-treatment assessment. It is also used for the assessment of the follicular maturity, the endometrial receptivity, the time of trigger, and so on. Looking at the uterus, if it is, I did tell you that if it is deviated onto one side, that's when you would suspect either it is a Mullerian abnormality, which may be a unicornate uterus, or it may be a bicornate or a diadelphous uterus, or there may be a pathology in the uterus involving the lateral wall, or there may be an adnexal pathology, which is pushing or pulling the uterus onto one side. But the uterus will always not be just twisted, just deviated. Sometimes it is twisted. So you will not see the midline, the mid-sagittal plane of the uterus in the longitudinal position of the probe. You may need to rotate the probe to get to the true mid-sagittal plane. And it is in this cases that you know that the uterus is twisted, and it means there is either there are other adhesions, or there is asymmetrical involvement of the uterus in some pathology. Coming back to the duplication abnormalities, yes, of course, if the uterus is deviated, that's when you would suspect a possibility of either a unicornate or a diadelphous uterus, but always the uterus duplication abnormalities may not be just a diadelphous uterus. It may be a bicornate uterus, it may be a septate or an arcuate uterus. This can be suspected when on the transverse section you would see a dimple on the fundus, or you would see division of the endometrial cavity into two at on the fundal end. And when you angulate your probe further towards the serosa, that's when you would also observe the normalcy, the smooth curvature of the serosa. If along with the curvature, the concavity or the division of the endometrial cavity, you also see a concavity on the serosal surface of the fundus, that means that it is either a bicornate or a diadelphous uterus. But if you see that there is the fundus is smooth, it's more likely to be a septate uterus. But for all the duplication abnormalities, and for that matter, even for the for all the Mullerian abnormalities, it is a 3D ultrasound, which has proved itself to be an investigation of choice, because it shows the coronal plane of the uterus, and it also shows the serosal and the endometrial surfaces together to allow you to differentiate between different Mullerian abnormalities, like a normal uterus, a septate uterus, a bicorporeal septate uterus, a subseptate uterus, a T-shaped uterus, and a unicornuate uterus. Of course, there's not enough time to take you through through all the differential diagnosis of this duplication abnormalities or the Mullerian abnormalities. But it is important to understand here that the transvaginal 3D ultrasound has proved to be extremely accurate in detection and classification of the uterine abnormalities, and it seems to have replaced endoscopy as a gold standard technique for the diagnosis of septate, and therefore that matter all duplication abnormalities. Not only the diagnosis of the duplication abnormalities, it also allows you to evaluate the curvature, the angle and the curvature between the endometrial surfaces, allows you to quantitatively evaluate the D-shaping of the serosal surface, and also if there is a septum or it's a bicornate uterus, allows you to evaluate the depth of the dividing endometrium or the dividing wall of the endometrium, which if it is extending up to the internal os, we would call it a complete septum, and short of that would be an incomplete septum. So it's a very important investigation, and not only just for the diagnosis, can also be proved to be a useful tool. As I told you, for the bicornate uterus, whether whichever classification you use, whether AFS or it is an hereditary classification, for bicornate or a bicorporeal uterus, it is essential that there would be a notch on the fundus, and this notch is deep enough so that the distance between the intercornual line and the deepest point on the notch is either less than 5 millimeters, or the depth of the notch from the line touching the tips of the endometrial cavity would be more than half of the myometrial wall thickness. It is in these duplication abnormalities, especially the bicornuate uterus, that we also look at the differential diagnosis based on the cervical shape and maybe a unicollis didelphys with a bicornuate uterus with a unicollis cervix or a normal cervix, or maybe a cervix which presents as a single muscular complex with two canals and cervical canals and a thick muscular wall in between, which would be a bicollis uterus. And if at all there are two separate muscular complexes for the cervix, then it would be a didelphys uterus. Coming to the T-shaped uterus, of course, the AFS classification does not clearly define the T-shaped uterus, but according to the ASHRAE classification, a T-shaped uterus is a uterus which has a thick lateral wall, and because of that thick lateral wall, there is a narrowing of the endometrial cavity where the uterus-cervical ratio is normal. So that is what is a T-shaped uterus. Of course, for the diagnosis of all the Mullerian abnormalities, 3D ultrasound with rendering is an excellent modality, but in all those cases where the scan is done in the early proliferative phase or where the endometrium is not healthy and it is thin and all, and a poor contrast is all in all these cases, that it's worth using OmniView, a special software for the 3D, which would allow you to evaluate the endometrial shape much more precisely. Coming to acute endometritis, so coming to the acquired abnormalities, acute endometritis can be diagnosed by a thick endometrium with a regular junctional zone and increased vascularity of the endometrium in the early proliferative phase, when generally you expect the endometrium to be thin, non-vascular. Whereas if it's a chronic endometritis, you would see a persistently thin endometrium usually, and you would also have an irregularity of the junctional zone, but sometimes you may see fluid in the endometrial cavity with the hyperechogenicity of the inner wall, no vascularity in the subendometrium, contracted or narrowed down endometrial cavity appearing very similar to the T-shaped uterus, or there can be a scarred uterine cavity too. Apart from this, we know that whenever we are suspecting chronic endometritis, that's when Cox is a quite common pathology that we always think about. There are some specific features, I would not say specific, but there are some features which are more common in tuberculosis, and that is one, micropolyposis, hyperechoic flex or calcifications in the endometrium, in the endomyoid junction. And sometimes in the myometrium too, you would have irregularity of the endometrial wall, which on the mid-sagittal plane, even if the fluid is not present, would be seen as irregular central line. And a very, and I would say the most specific sign would be vertical orientation of the and interstitial part of the tube. So these are all signs which may indicate a possibility of tuberculosis, but remember, this only indicate a possibility of tuberculosis. The confirmation is to be done by histopathological examination after taking a biopsy from the affected areas under hysteroscopy from the endometrium. Polyps are solid lesions, and they are arising from the endometrial wall, seen as solid soft tissue echogenicities in between the endometrial lines, especially best seen in the periovulatory phase where the endometrium appears multilayered, and Doppler is quite diagnostic of it because it shows a single feeding vessel which is specific of a polyp. When large polyps, they may fill up the entire endometrial cavity and may raise a doubt of a hyperplasia. Whereas when the polyps are very small, that's when you would only see the deviation of the central line. And when you concentrate there, you would see a very subtle solid shadow, a soft tissue shadow, which is probably a polyp. Again, it is the Doppler which would help you differentiate it from other abnormalities. Sometimes polyps are pedunculated, and it is in these cases that the polyps would move with peristalsis, and they actually mimic clots, and therefore it's very essential that you will always you do a scan and confirm the possibility of a polyp, confirm the diagnosis of a polyp only in the periovulatory phase and not during the menstrual phase. As I told you earlier, when the polyps are large and fill up the entire endometrial cavity, that's when it's possible. It is sometimes very difficult to differentiate it from hyperplasia and also from malignancies. It is also the doubt also is raised when the feeding vessel of the polyp divides into multiple. When the feeding vessel divides into multiple and the polyp appears heterogeneous in ecogenicity instead of homogeneous, that's when there is a possibility of either adenomyomatous polyp or sometimes sometimes atypia and a doubt of malignancy. Hyperplasia, though, shows a more generalized thickening of the endometrium. But remember that whenever there are multiple polyps, even then the entire endometrium may look hyperechoic. Yes, of course, it is true that it is the feeder vessel, the single feeder vessel, as you can see here, which may be diagnostic of a polyp, but it is also important to remember that when there are multiple polyps, which make the entire endometrium look hyperechoic, that is when each individual polyp will have a individual feeder vessel and therefore would appear very similar to that of hyperplasia, which you're seeing here, which shows a regularly distributed normal vascularity and intact junctional zone. Hyperplasia, if we talk about, there are two types of hyperplasia, one in which there is more of a stromal component, which appears more hyperechoic and shows anechoic areas, but they are very small. And it appears a little more hyperechoic than the cystic or glandular hyperplasia, wherein, of course, the endometrium is thickened, but you see multiple anechoic areas, and these are larger comparatively, and they are variable in size. So that is, and more commonly, the cystic glandular hyperplasias are less vascular. Whether it is hyperplasia or malignancy or it is polyp, the differential diagnosis can be well done by using saline infusion, sonohysterography, and doing a 3D ultrasound. Of course, even without a 3D, you can beautifully see beautifully identify the endometrial pathologies, but of course 3D is almost comparable to the hysteroscopy, as you can see in this image, you can see in this image too. So the polyps, for any endometrial lesion, therefore a saline infusion sonohystero is indicated. This is also sonohystero with a 3D ultrasound, especially to demonstrate the synechy. It is 3D, which would allow you to not only diagnose synechy, but evaluate it more thoroughly, identifying every synechy and also identifying the thickness of this. And also, when you inject saline, it would also allow you to diagnose the amount of restriction of the cavity because of the synechy. Endometrial calcification, whenever it is seen, it is very, very essential that you always do a 3D, because an endometrial calcification, which appears like very thick and in thin slit of calcification and may not even affect the endometrial receptivity, but sometimes it would be endometrial, sometimes the endometrial calcification may be really thick and involve the entire endometrial thickness. So if you want to evaluate the impact of this calcification on the implantation, it is essential that one would always do a 3D for any calcification that is seen in and around the endometrium. Sometimes you may see heterogeneous ecogenicities in the endometrium. And endometrium, it's very common to say this. This is usually blood in the endometrial cavity. There are various reasons which may be found out by the history of the patient. What would be the cause of blood? Maybe missed abortions, maybe threatened abortions, maybe recent menstrual period, maybe a recent surgery, a DNE, etc. So it's very essential, of course, identify blood in the endometrial cavity and find out the reason from the history. Coming to adenomyosis, we all know it is a heterogeneous myometrium with a globular uterus, which may be symmetrically or asymmetrically involved. There may be hyperechoic islands, there may be hyperechoic dots and lines, there may be anechoic myometrial cysts, which are seen in the myometrium. There are alternate vertical hyperechoic shadows, which are called fan shadows. There may be abnormal curvature of the endometrium, which is this abnormal curvature is seen towards the fundal end of the endometrium, and it's actually a reverse curvature, which is described as a question mark sign. Now, apart from this, in cases of adenomyosis where there is myometrial cyst, which appear as anechoic shadows in the endometrium, they are surrounded by vascularity if it is adenomyosis. Moreover, in the adenomyosis, the vessels have a larger diameter than the normal spiral vessels, as you can see here, and the vessels are chaotically arranged, unlike the normal spiral vessels, which are parallel to each other and they are perpendicular to the endometrium. Apart from this, junctional zone assessment is a very, very important part of the ultrasound evaluation in cases of patients in whom adenomyosis is suspected. In cases of adenomyosis, junctional zone may either be irregular, as it is seen here, or it may be obliterated by hyperechoic dots and lines of the endometrium. Sometimes it is inaccessible, and these are all very important. So apart from the direct signs of adenomyosis, which is hyperechoic islands, hyperechoic dots, lines, and myometrial cyst, it is the junctional zone irregularity which is the most important indirect sign of adenomyosis, and that is what you can also see on your 3D. You're seeing irregularity of the junctional zone. Not only irregularity of the junctional zone, you can actually see the endometrial strands extending into the myometrium. Question mark sign, one more image which demonstrates the question mark sign beautifully. One of the important signs of adenomyosis. Coming to fibroids, more well-defined, rounder oval, lobulated, sometimes lobulated lesions, most often roll appearance with hypoechoic echogenicity and a slight peripheral hyperechogenicity, but sometimes it is also heterogeneous in echogenicity. Usually when degenerated, the fibroids appear heterogeneous. This heterogeneity may be in the form of hyperechogenicity, it may be in the form of cystic degenerations, and sometimes it is calcification of the rim, or sometimes calcification in the endometrium also. But remember that though the confirmatory sign of adenoma of fibroid is peripheral vascularity. Whenever there is a degenerated fibroid, that is when apart from the peripheral vascularity, there would also be internal vascularity of the lesion, but these internal vessels are marginated by the peripheral vessels. And they don't, and they respect the margins of the fibroid. Whereas in adenomyosis, apart from the other features of the vascularity of adenomyosis described, it is important to understand that these vessels, they disrespect the margins of the lesion in adenomyosis, and they run through and through. So this is called a peripheral with intralesional vascularity, and that is called a translesional vascularity of adenomyosis. But remember that not all adenomyosis and not all fibroids are hypervascular. Those which are hypervascular would respond well to the medical line of treatment, but those which are not hypervascular will not respond well to the medical line of treatment. Fibroids, when we are talking about, they can be of various sizes, then they can be of various shapes, they may be single or multiple, and they may also have they may be seen in different layers of the endometrium. Sorry, that's not working. But yes, you can see here the fibroid which is far away touching the serosal, which would and that's a subserosal fibroid, whereas this is pure. This appears to be absolutely in the endometrial, subendometrial fibroids, and then you may also have intramural fibroids and fibroids like this, which extend right from the endometrium to the myometrium, depending on the penetration based on the palm coin classification or the FIGO classification. You need to always type the fibroid. That means you need to always describe the penetration of the fibroid. Not only that, it is essential that whenever you see fibroids, that's when you must write the number. You must report it in a following format, where you would write the number of fibroids, 1, 2, 3, 4, location, anteposterior wall, right, left wall, upper middle, lower third of the uterus, type is penetration, size of the fibroid in three longitudinal orthogonal diameter, three longest orthogonal diameters, echogenicity of the fibroid, shape of the fibroid, margins of the fibroid, vascular pattern, whether it is just peripheral or it is internal vascularity too, or it is a translational vascularity and it is not a fibroid, or it's a, and also write the vascular score. No vascularity is score 1, minimal is score 2, moderate is score 3, and abundant vascularity is reported as score 4. And it is also essential to always draw a pencil diagram locating the showing the location of individual fibroid and its penetration correctly. Of course, 3D is of a great help, especially when there are not multiple fibroids, just one or two. That is when, and it is 3D is also of a great help to identify, to clearly demarcate the involvement of the endometrium, but it's not always possible to, not always easy to show multiple fibroids, and therefore fibroid mapping with a pencil drawing is very, very important. Coming to the the IUCDs, the exact location can be seen beautifully on ultrasound, whether it is normal in placement or it is displaced, and it is 3D ultrasound, which helps better to locate the position and also identify the type of the IUCD used. Scars in the uterus are very important to evaluate. These are all healthy scars where you do see a posterior shadowing, which is because of fibrosis of the anterior wall or the serosa of the uterus, and there are no fluid collections. These are all healthy scars, whereas when there's fluid collection, especially triangular shaped fluid collection in the in the scar, it is usually called as an isthmosal, and it is in these cases that it is essential to measure the scar thickness, of course, in the non-pregnant state first, and then in the pregnant state, but because it's quite difficult to evaluate the scar thickness correctly in the advanced pregnancies. So the scar thickness is best evaluated either in a non-pregnant state or the first trimester of the pregnancy at the most. Coming to the adnexal lesions, there would be clear cystic lesions, especially talking about the ovary first, and it may be a residual follicle. It may be an active follicle of the same cycle. It may be a follicular cyst. Follicular cyst, remember, we term it as a follicular cyst only when the cystic lesions are larger than 25 millimeters, and there's no vascularity. Follicles, whenever they grow beyond 10, 11 millimeters, they start showing vascularity, or there may be a luteinized unruptured follicle where you have low-level echogenicities and thick inside the lumen and thick hyperechoic walls with scanty vascularity. Sometimes there may be hemorrhagic echogenicities inside the cystic lesions, and this is also physiological. There may be a corpus luteum, which shows excellent ring of color. Whereas if there is no flow at all with the similar hemorrhagic echogenicities, we would call it as a hemorrhagic cyst. Sometimes there may be a residual active or regressing corpus lutea, where you still see hemorrhagic echogenicities inside the cystic lumen, but you would see only scanty and a high resistance flow. Corpus lutea, though, it must be remembered, may have varied appearances. As you can see here, different corpus lutea, and sometimes they may also appear absolutely isoechoic, and it's only by the color Doppler, the ring of color, that you can make out yes, there is possibility of corpus luteum there. But a good observer may definitely be able to suspect it strongly on the 2D assessment. Hemorrhagic cyst is what we talked about already. Remember, hemorrhagic cyst is a term used only for those corpus lutea which have stopped functioning but anatomically not regressed, so they are hormonally not active and would not show any flow at all, though the contents of the cyst are hemorrhagic. Endometriomas, commonly seen ground glass appearance, as you all know, but may have varied appearance, may be heterogeneous, may have debris-like shadows with low-level echogenicities. Typically, it has short course vessels which approach the walls of the endometrium but does not run with it. One, it has a possibility of adherence and tenderness on probe pressure, which would identify the endometriomas. One more specific sign is hyperechogenicities in the flex of the hyperechogenic flex in the walls of the endometriomas, which may be because of either hemosiderin or cholesterol deposits. Endometriosis, deep endometriosis, is well diagnosed on ultrasound. And yeah, It's well diagnosed on ultrasound following the muscularis of the bowel. When you angulate your probe a little more posteriorly towards the posterior fornix and travel deep inside with the probe traversing, and looking at the entire anterior muscularis, you would locate areas which appear as irregular hypoechoic shadow, D-shaping the anterior muscularis of the bowel, and with or without hyperechoic flex inside, irregular walls, and hyperechoic margins, which is because of muscular hypertrophy, as you're seeing here also. Yeah, that's going to come up. Yes, so that is endometriosis. Painful and pressure adhesions possible is diagnostic of endometriosis. Dermoids, typically 2D diagnosis, may appear as cystic lesions with low-level echogenicity, sometimes with hyperechoic lines, sometimes with hyperechoic dots, hyperechoic tooth-like shadows with posterior shadowing, hair balls floating inside, hyperechoic blades with posterior shadowing. There may be fluid label, a vertical fluid label, where this is the hyperechoic is the sebaceous material, and that's the fluid, hyperechoic sebaceous material floating over the fluid. Sometimes you may see hyperechoic ball-like lesions, where the posterior margins of the lesions cannot be identified because this is fat. And therefore, fat being a poor transmitter of sound may not show the posterior walls. And that is, if it is intra-ovarian, which can be identified by the ream or the beak sign of the ovary, would tell you, yes, it is a dermoid. So that is called as a tip of the iceberg sign of the endometriomas. Pelvic infections like tuberculosis or any other reason for PIDs will show fluid in the endometrial cavity with or without septation, sometimes a lattice-like pattern with low-level echogenicities, and sometimes even present as floating cysts in the fluid with low-level echogenicities. And of course, the typical history would with tenderness would lead to the diagnosis. If the ovary is involved, it may show unexplained hypovascularity, sometimes may show ovarian calcinosis, and may also show small follicles with a ring of hyperechogenicity, very similar to that seen on the torsion also. But tuberculosis, when the follicular ring sign is because of tuberculosis, there are no acute symptoms that differentiate it from torsion. Para-ovarian cyst can be identified by its extra-ovarian location, no echogenicities inside, no solid projections, no vascularity, no septa. Any lesion, though, which is extra-ovarian, can be identified by what is called a sliding organ sign. If you can separate the lesion from the ovary, or you can slide the lesion on the ovary, would tell you it is an extra-ovarian lesion sometimes. But whenever you see such lesions, always try and establish its proximity to the fimbrial. Because the fimbrial cyst, if present, has no significance, but the rest of the cystic lesions may have a significance. Hydrosalpinx can be well identified as a cystic lesion, extra-ovarian in the adnexa, which changes shape on rotation of the probe, may have a typical trumpet-like appearance, where one end of the hydrosalpinx is narrow, where the other end may be wider. Thicker walls and the thickened mucosa shows as solid projections inside. This walls may also show hypervascularity, and that would indicate acute inflammation with hydrosalpinx, but not always would be would the presentation be the same. Sometimes it has thin walls, and it may also thin hyperechoic walls may show alteration or elongation on rotation of the probe, incomplete septa would all, and sometimes it may show even absolutely serpentinous appearance. Sometimes may also appear as not very thick, not very wide lumen, but fibrotic, thick echogenic walls, and these are all hydrosalpinges. But if the ovary is also involved, we may also see tubo-ovarian masses where the ovarian tissue and the hydrosalpinges cannot be separated, and sometimes cannot even be distinguished. So that may be an tubo-ovarian abscess. Tubal patency testing can be done either by injection of the saline, where you can actually see saline flowing outside, or you can use color Doppler. When you use the color Doppler, that's when you have to observe the color blush filling up the box surrounding the ovary, as you are seeing here now. and that would tell you it is a patent tube, or you can use use contrast and do a hycosy, where you can see the entire tube as a hyperechoic clear structure with the femoral land on the contrast mode. 3D with hycosy can give you a better idea about not only the tubal lumen, but also the femoral condition. Then coming to the baseline scan, which is done day 2 or 3 of the cycle to assess the ovarian reserve and the response. The reserve is assessed by the antral follicles and the size of the ovary, and the response is assessed by the blood flows in the ovaries. Antral follicle count can be counted by 2D ultrasound just by scrolling across the ovary only in one direction without the rotation of the probe, eyeballing and counting the number of follicles, as you can see like that. Or you can use a sono AVC if there are multiple follicles, but number of follicles when they're less, using any of the two, it doesn't make much difference in your results. The stromal flow is essential to evaluate to assess what should be the daily dose of gonadotropins, because if the flow to the ovary is more or less, gonadotropins would be required daily to reach the FSH threshold, whereas if the flow to the ovary, the ovarian stroma is less, that's when more gonadotropin would be required as a daily dose. So that is, and there are parameters which would tell you patient is going to require higher doses for stimulation or lower doses for stimulation. So that is about the baseline scan. The baseline scan is also done to identify, to confirm the diagnosis of polycystic ovaries. Of course, multiple follicles, peripherally arranged, or sometimes even generalized arrangement of these follicles. These follicles can be counted, of course, by sono AVC, but it is the stromal hyperechogenicity or the stromal abundance which needs to be confirmed either by echogenicity, either by stromal area or by the stromal volume, which can be done by 3D ultrasound as well as by the 2D ultrasound. Follicular maturity can be assessed, cannot be assessed only by the 2D ultrasound. It needs a Doppler assessment of the follicle, not only just the subjective idea, but you also need to find out the RI and the PSV. The vascularity should cover at least 2/3 of the circumference to say that the follicle is mature. 3D may sometimes help to locate the cumulus too. Endometrial maturity can be assessed by looking at the endometrial thickness, morphology, vascularity that is reaching the inner layers of the endometrium with a low resistance flow, and the uterine atrophy, which has which is less than 3.2. In difficult cases where the endometrium is persistently thin, or the endometrium shows, or there is a patient with an unexplained failure of implantation, that's when endometrial volume assessment and the 3D vascularity can also be a useful tool. The surge, when it starts, it leads to increase in the velocity of the perifollicular flow. Based on the velocity of the perifollicular flow, one can decide whether the surge has already started. And it is in these cases that one can also decide whether the patient would require a single IUI or at a regular time, or would require either a double IUI or an earlier IUI. Typically, the trigger choice can also be decided by ultrasound. If there are multiple follicles, especially this happens when there's a gonadotropin stimulation, more than 25 follicles of larger than 11 millimeter total in both ovaries together, that's when you would not prefer to give any HCG at all. But if the number of follicles, medium-sized follicles, 11 to 14 millimeter or less, you can still give HCG, and HCG has an advantage of preventing the luteal phase defect. Therefore, it is essential to evaluate the ovaries also with the sono AVC when there are multiple follicular development, even before the trigger. The effect of progesterone on the endometrium can be evaluated by the endometrial morphology. Fluffiness of the outer margin of the endometrium tells you there is an early exposure of progesterone, which is physiological and is a preferred scenario for before the IUI is done, or before the triggers, or just when the trigger is given. Whereas if the outer margin of the endometrium starts getting hyperechoic, that's when it is either pathological levels of estrogen, pathological levels of progesterone, or it is more than 24 hours exposure of the endometrium to progesterone, which means it has this endometrium has a poor receptivity, whereas this fluffiness of the endometrium has a good receptivity. Not only that, progesterone effect also shows as decrease in the vascularity along with the decrease in the thickness because of compacting effect, and that all together. So fluffiness of the outer margin of the endometrium, decreased in thickness, decreased vascularity would tell you that the surge has already started. And it is only after about 2 to 3 days of the progesterone exposure that the endometrium again starts getting hyperechoic, thickened, and hypervascular. And this can be correlated with the follicular status to decide whether, again, whether the surgery started or not, and what time would the IUI be best done. So ultrasound is the single most important investigation for assessment of the patient with infertility before the treatment, as well as for the planning and monitoring of the treatment. Doppler has special role due to its correlation with the hormonal changes, and 3D adds to the information. Thank you very much for the patient hearing.
Welcome, ma'am.
Thank you.
Nice
Thank you
presentation,
so
madam.
much.
Thank
It's
you.
an honor to listen to it.
Thank you.
And many times I listen, I still get some new points to ponder.
Thank you so much. Thank you so much, Dr. Ashish. Thank you.
Abha, madam?
So, thank you, Sonal ma'am. I'm your student. Whatever I learned in this, I've learned from you. And just wanted to introduce everyone to this. Those, not for the infertility specialists, but the normal gynecologists. That, this is the scope, this can be done, and this needs to be done. So, you really said it so beautifully. Thank you so much. Thank you so much.
Thank you.
Sujayasri? Sujayasri, Anuradha?
Hello, hi, ma'am. It was very nice, elaborative talk. Very good tips for us.
Thank you.
And ma'am, very nice. Okay. And we'll move to the next section, madam.
Yeah. Can you see my screen?
Yes, ma'am.
My whole problem is, yeah. Anuradha, would you introduce sir? Anuradha?
Yes, ma'am. Yes, ma'am. Everybody knows
Please
him,
introduce
ma'am.
Ashish sir.
Yes, ma'am. First of all, he was my senior when I was doing postgraduate in my college. So I know him very well. And he's the director of Asha IVF centers and like Foxy membership, and he's very family welfare committee chairperson. Ma'am, I'm not getting the CV slide, ma'am, please. Ma'am, please, CV slide.
Yeah, just a second. Where it has disappeared, I want to know. I had just put it up. Can you see it now?
Yes, ma'am. Yes, ma'am. Now I'm able to see. And he's the treasurer of ISAR in 2024 to 2026 and Family Welfare Committee chairperson FUXI 2023 to 25 and executive member IAGs and so more. He's very active member in FUXI, in ISAR, in IFS, in ISOPAW, and recipient of Legend of Gynecology by BOGS 2024, FUXI Foxy Badlav Award in 2024 and IAGE AGL Skill Excellence Award in
Thank you.
2023.
Thank you for those lovely introduction.
Award in
May
2020.
I allow
So many
my screen to
awards
show?
so many awards
Okay.
in his bag, and he's a very eminent speaker and teacher. He teaches in all his Facebook. Everybody follows him very and like it very much. Thank you, sir. Thank you. Now again.
Thank you. Hope my screen is visible and I'm audible too. Today we will be talking about the evaluation and management guidelines for infertile couple. When you're talking about the guidelines, what I should be understanding that whenever we are knowing that all of us are practicing the infertility, but when to treat it, and there has to have some guidelines in order to follow what the things to be done and what things not to be done in the a set area of your practices or in a community. So today I will be talking about, when we're talking about the evaluation, we must know the infertility nowadays is a rampant thing. So Dr. Hrishikesh Pai sir, he talked about the different aspects of infertility. I'll be talking about when to do a evaluation, what to be done, and what exactly to be take home messages. So without taking much of time, I need to first thank you and congratulations to Dr. Jain for electing as a chair in a Foxy and joining us in a Foxy in a big way. So thank you very
Thank
much
you, sir.
for
Thank you.
giving me opportunity, and madam, all the best wishes to your endeavor in Foxy. Looking forward for many ventures in your life to come across. So we have things that whenever there is a patient of 35 age and more than 35 age comes down to us, then does the infertility treatment or the definition makes a change? Is do, because when you're talking about the infertility, it is failure to conceive within the 12 months of unprotected sexual intercourse. It affects 8.8% in the age group of 15 to 49 years. But whether you are going to wait for so long when the patient is more than 35 or more than 40, the issue is that whenever you are waiting for a longer time, you will be wasting the patient's that golden years of fertility. So when the patient of age 45 or 40 or 42 comes down to you, it may that you may to work upon her, or you may to start some fertility treatment for her, because she needs to have some fertility assessment treatments when she is not able to conceive a 6 months of her period. The causes of female infertility, we all of us knows that the sperm and the female partner as the male partner has the same potential of 35 to 30%, but there are certain factors which comes as a couple, and that needs to be addressed also. We know and do understand the ovarian dysfunctions contribute to 25% of the situations. Sperm defects is 30%, unexplained infertility 25%, the tubal factors or maybe a chlamydial infection is 20%. The endometriosis, all of us knows that we when to operate, when not to operate, comes down to 5% of it. The failure of or infrequency of sexual intercourse is 5%. Why it is so important? Because when you are talking about the evaluation of the infertility, the first part of the evaluation starts with how you should address as a patient, as a couple, and not as an individual, because most of us are they are doing the gynecological practice, but this is the field wherein as a consultant you have to treat the couple as an entity, because the male and female factors are equivocal. So cervical mucous defects has contributed to the 3%, and the uterine anomalies is less than 1%. Saying so, we need to understand the causes of infertility is the occurrence, and it is going to have occurrence, and the same preset may not be a same contributing factors. There may be a multi-directional factors or multi-causative factors for the same patient. The time to study before it is called as infertility, we need to talk to the patient what is the duration of married life, duration of the sexual life, because in our country or maybe in a metros, we thought that the people do have the time for all these things, but usually there is a because of the IT companies and because of the job profile, the couple usually meets on the days or the weekends where the fertility potential may be less, and that's why we have to take the detailed history, how much is the duration of the sexual life and the couple is going through, and is there is any use of contraception in the previous years, because some of the contraceptions like COCs or maybe a prolonged use of COCs or maybe the condom is responsible for a certain factors like anti-sperm antibodies for that matter, and for the COC users, if it is more than 2 years, the chances of quality of formation of the eggs may be deprived of. The history of any sexual relationship in the past, because there are the certain problems that has to be addressed, like a sexual dysfunction. Usually the patient has a good relationship in the past, in a sexual relationship in the past, but in the present days of the practice or maybe in the present situation, he or she may not be having that sexual pleasure with the partner where she is having it. The fertility outcome in such a relationship should be discussed, because she may have the previous relationship and may end up into a different altogether background, and that has to be talked about, because that may be the mental trauma for her, and that needs to be addressed in a large depth. The history of the family planning procedures, you need to talk to her whether she is a LARC users or she is using temporary methods of contraception. We must know the story of her, and the story of her in the past, like the history is an important thing. The story of her in past, like a medical history of the thyroid, diabetes, tuberculosis, PIDs, and epilepsy, because the diabetes, long lasting diabetes, may hamper your quality of the eggs, we know, and the duration of her to have the pregnancy. The tuberculosis and the PID, again, it is a disease in India which is common as a tuberculosis, and the tuberculosis causes dysfunction in the uterine endometrium formation, as well as the PID in the tubo-ovarian relationship. The surgical history is also important, because the evaluation starts with the history taking, and that's why I'm giving much more importance to all these histories. The surgical histories is a previous history of the laparotomy or the laparoscopy, wherein she is going to get operated on the ovaries or maybe the appendix, which may causes adhesions and which may cause tubo-ovarian dysfunctions or tubo-ovarian angle dysfunction. The contraceptions, IUCD users, or maybe she has undergone the tubectomy, and when she has come down to you for the fertility treatment, then you have to think twice whether I will be going with the laparoscopic tubal reanastomosis, or I will be going for the IVF. I will be covering that in a little while. The previous obstetric events like the MTP, DNC has to be taken into account, because that will give a physical as well as the mental trauma, and the DNC per se will have a dysfunction, uterine bleeding, or maybe the Asherman formation. The drug allergies and the intake, smoking and alcohol also plays the important role in evaluation of the fertility for her, because the smoking and alcohol detrimental effect on her psychological behavior as well as the reproductive capacity. The profession, if she is in, as I started with my talk, that if she is a professional and she has a long distance relationship, that has to be taken with a pinch of salt, whether they are going to have productive days for the procreation. The evaluation starts with the history as well as the examination of the each partners. We need to take the of the history of the menstrual history, whether she has a regular menstruation, irregular menstruation, whether she has the signs of ovulation, that has to be stressed upon. Also, we need to take the detailed history of the coital history, that whether it is a painful coitus, whether it is a coitus, whether she has that arousal, whether there is any difficulty in while they have the intercourse or the penetration, that has to be talked about. I already given the importance for the history of addiction, history of medical illness, but there has to have some history taking as far as the diet she consume, because nowadays we are seeing the many couple with the high BMI, and the BMI, if it is more, then it is a detrimental effect as far as the ovulation is considered. So we need to take evaluation from the history and then come down to the evaluation with the pelvic examination. The pelvic examination start with the inspection, whether the private part has an infection, whether she has the genital herpes, maybe there is a fungal infection. So just by the infection, you will get the clue whether the patient is having the infective pathologies, and then you can evaluate further on. The per speculum in the examinations will be going to give you a much more importance about the fungal infections or maybe STDs, as well as the cervical status, whether the cervix has a erosion or maybe there is a cervical growth, or that can be addressed later on. The per vaginal examination will be telling you whether it is associated with the TO masses, or whether the uterus is fixed or the retroverted, because that will gives you indirect evidence that you are dealing with the endometriosis or maybe the PID cases. The what factors to evaluate in the female infertility will depend upon the ovarian reserve first, then the tubal factors, uterine factors, and the cervico-vaginal factors. So we'll go one by one how to evaluate and what is the guidelines are all about. Coming down to the ovarian factors, according to the WHO, the ovulatory dysfunctions contribute to the 25% of the infertility. When it has been the menstrual cycles, because whenever I specifically talked about the menstrual history, it will related to the what is the duration of the menstruation, what is the frequency, if she is oligomenoric or there is a amenorrhea or there is a drug-induced menses, that will definitely tell you she is the patient wherein the anovulation is the factor and you need to correct it. The most common causes of the anovulation in ASRM, according to the ASRM, is the 70% all of us has the PCOS patients. The thyroid dysfunctions may contribute to the 2 to 3%. The pituitary diseases is 13%. Maybe there is a adrenal hyperplasia or maybe adrenal gland tumor contribute to the 2% of the ovulation dysfunctions. If we know all these things, what we need to as a evaluation comes down to us is a step by step approach. First, to take the detailed history of the patient, then by the pelvic examination, then you come down to the ovarian factors, wherein because already you have taken the menstrual history, you will correlate that she has a irregular menstruation or may she has ovulatory dysfunctions, and that can be corrected by giving the oral ovulogenics or maybe the fertility treatment later on. What are the guidelines is? This is the 2023 guidelines of the ISHRE. The woman with the regular menstruation cycles, the test of confirmation of ovulation is not recommended. This is generalized statement by the ISHRE guidelines. The woman with the regular history of menstruation, if confirmation ovulation is warranted, then you can do LH kit, and that can be a conditional, and that is only where she won't wish to know whether she is ovulating or not, and that can be advocated. Secondly, the oocyte or the luteum quantity. If the patient is having the regular menstrual cycle, it is suggested not routinely measure the mid-luteal serum progesterone. And that's why when you are talking about serum progesterone measurement, it has to be done on 21 day of the menstruation, if at all you wish to do. But if the patient is having the regular menstruation, it is not been recommended. In the woman with the investigations of infertility, the endometrial biopsy for histological examination is also not recommended. So these are the previous days where the people are used to do the endometrial biopsy, and the endometrial biopsy will show whether she is having the secretory changes in the endometrium. But according to the 2023 ISHRE guidelines and ASRM documentations, it is not been recommended as a routine practice. So here is the flow chart, and this is the $1 million flow chart. As far as the ovulatory dysfunctions and the guidelines is considered, evaluate the clinical evidence of ovulation by taking the menstrual history, whether the menstrual history is constant, whether she is having irregular menstruation, whether she has a regular menstruation, premenstrual symptoms like the breast tenderness, the fluid retentions during the luteal phase of the menstrual cycle, has to given the most important thing when you're talking about the menstrual history taking. Though there is no clinical evidence of ovulation, evaluate the ovulatory dysfunctions, check for the PSA, check for prolactin test, check for FSH and LH levels. You will come to know with this hormonal evaluation whether the patient is having the PCOS or not. The treat underlying cause, if she is a hypothyroidism, corrected, because according to the ISHRE, if you go, what is the normal TSH level should be between the 2 to 2.5 in order to achieve the healthy pregnancy. Consider ovulation induction at least for 3 cycles, and if that fails, then you need to go with the higher line of a treatment. The clinical evidence for the ovulation is to first test the ovarian reserve, evaluate the tubal patency, evaluate intrauterine anomalies if are there by ultrasonography. I will come down to that in a little bit. The evaluate of the treating cause. If the treating cause is been evaluated, also evaluate the male factors. And if the woman is more than 40, definitely clinical evidence of ovulation is needed. You need to do a follicular study. And Dr. Previous speaker, she was talking about how to evaluate. Panchal madam, she already talked about what is the dominant follicles and what is RI and PSV. You need to give a little bit importance to this particular patients. If the patient is more than 40, you need to escalate the treatment of the ovulation and ovulation studies and more than that. If you are unclear about the ovulation history, serum progesterone levels, then you can do help of the serum progesterone levels at the day of 21. If the serum progesterone levels is less than 3 nanogram per ml, evaluate as it is an ovulation, then definitely you need to go further to evaluate into the anovulation studies more. The ovarian results test, again on day 2 and nowadays we not do a FSH routinely. We're not going to do about the fallopian challenge test, but definitely we are going to do the day 2 scan to know what is the AFCs are and what is the day 2 during the any day of the cycle. You can do a serum AMH levels, and the serum AMH levels will tell us whether she is a normal responder, she is a low responder, or she is hyper responder. And similarly, on day 2 scan, you will able to understand what is the what is the AFC, whether the AFC is good or not, whether the AFCs are diminished, and then we'll reveal that it is a diminished ovarian reserve or maybe the hyperstimulation patients. If the AMH is less than 1, definitely that patient is of concern, and definitely you are going to go with the IUI stimulations or maybe the IVF stimulations directly. I will not go into the details of it about the Poseidon criteria, where we know that there is a group 1, group 2, group 3, and group 4. Group 1 and group 3 are the young patients. Group 3 and 4 are group 2 and 4 are the older age patients. So we are not going into the details of it. Definitely, we are talking about when the patients are coming down to us, what the evaluations to be done at the age where the age is 40 and more than that. Definitely you are going to do the AFC, and where we are going to do the serum AMH levels. The ovarian factors for the ovarian reserve, but it is not been recommended. There is a strong recommendations that one should not be required this kind of a test or the AMH, where the only to just to know the probability of the spontaneous conception within the 6 to 12 months. So what the ISHRE recommends, the AMH is not the testing of the tool where it will tell you that the patient is going to become pregnant, or this is not a predictive tool where you can tell to the patient that she is going to become pregnant in a 6 to 12 months. And that's why it has not been recommended for all the patients to do the serum AMH levels. Coming down to the tubal factors, the tubal infertility is defined as either there is a block in the fallopian tubes or inability of the tubes to pick up that beautiful ovulation has been occurred, and the oocyte has been released, and that particular oocyte is not been going to take care by the inability of the tubes. Maybe there are hydrosulfings or there may be a damaged tubes, and that can be because of the pelvic adhesions, and that accounts for 11% or 67% of the diagnosis will occur in the population studies with what they quote on. The tubal infertility should be suspected in the woman with a history of the PID or sexually transmitted diseases, cervical dysplasia, abdominal surgery, or maybe a previous intra-abdominal infection like a tuberculosis. Why it is saying so? Because if you are giving into the details of the history, the evaluation becomes very, very easy. If she has the previous history of sexual transmitted diseases, or maybe she has the previous history of any operative or maybe intra-abdominal infections, that will give rise to the occlusion of the tubes, or maybe the fimria which has been occluded, or you may get the tubal blocks. So how to evaluate that? There are the guidelines that you can do a beautifully. Dr. Panchal madam has already talked about. You can do a hypoxia or you can do a HHG. What is the best? The best, you need to do all this, and this is the strong evidence for the tubal factor assessment. You need to do the HHG or hypoxia. HHG and hypoxia is comparable is a diagnostic capacity. Thus, the selection of the technique is depending upon the preference of the clinician and the patient herself. Because if you are master but you are not going to do interpretation, it is of no use. So it is been recommended by the guidelines that if you are not comfortable, you can advise for the HHG or you can do a hypoxia by yourself. The chlamydial antibody testing for the tubal patency could consider in a risk potential patients and not for the all. If she has the previous history of STDs, then definitely you will be doing this chlamydial antibodies testing and not for the all patients, because this will tell you whether the patient has had the history of the sexual transmitted disease in the past, and that's why it needs to be taken into account. The history with the high risk of the tubal abnormalities and the visual demonstration of the tubal patency is necessary. These are the guidelines by the ISHRE in 2023. So let's compare the literature. If the ISHRE guidelines telling us that we need to assess the tube by doing the hypoxia or the HHG, definitely it is going to give the pregnancy rate in a higher side. In fact, it is comparable that if you are doing the HHG with the oil-based as well as the water-based solution, oil-based gives a higher pregnancy rate, and this has been documented by the systemic review as well as the meta-analysis of the 6 RCTs. So sonosulfingography has equal sensitivity and the specificity. But if you are talking about whether I will be using oil-based dye for the HHG or the water-soluble dye, I will recommend that if you are asking your radiologist, it is better to use the dye with the oil-based, because it will give you a future pregnancies rather than just interpretation of the results. Hypoxia, definitely it has a sensitivity of 76% and the specificity of 67%, but it is the tool where you require little bit of expertise. The tubal surgeries for the IVF, it should be based upon the female partner's age. Whether the female is a more than 40 years, then it is better to go with the IVF because her ovarian reserve may not be that good where you are just doing the tubal surgery and allowing her for the spontaneous conception to occur. Secondly, the infertility duration that plays an important role. If you are going to do a tubal surgery or tubal reanostomosis, it is depending upon what is the duration of the infertility they had gone through, the presence of all other factors like the male factors of infertility or subfertility that has to be taken into account, because only for reconstruction surgeries and your male factor is hampered, it is not going to give a successful result. The extent of the tubal disease that has to be reassessed prior to the tubal surgery, because if you're doing the HHG and you find it there is no appropriate length has been there for the reanostomosis to occur and functioning of the tubes, that is an important part. The financial resources also plays important role, because if you are living in a tier 3 cities of India and you are talking about the IVF, its need of affordability that has to be talked about. The uterine, coming down to the uterine factors and the cervical factors, the factors that distort the uterine cavity includes the endometrial polyps, leiomyomas, intrauterine synecdoche, the congenital uterine malformation like the septate uterus. Then definitely you need to have a sonosalpingography or the HHG, which will definitely tell you about the factors that there are there for the cervical as well as the uterine abnormalities. But if you have a good 3D ultrasonographic machine, where always and the specificity of it is too high, and it is much more higher in detection of the complete septum, maybe a polyp, maybe a myoma, that can be definitely will be diagnosed by just doing a 3D ultrasonography. Now, what are the guidelines says that ultrasonography is preferable because it is non-invasive, and you can do it, and it is really a strong evidence to find it out what investigation you will offer as far as the uterine and the cervical abnormalities is considered. So then the ultrasonography with the 3D probe will be helpful. MRI is not recommended as the first line of a test for the normal uterine structures and the anatomy in the woman with unexplained infertility. Cervical vaginal factors, the post-coital test has not been recommended nowadays to just find it out what is the result of the infertility evaluation. The vaginal microbiota, all of us are talking about there is a microbiota which is helpful for the conception, but routine analysis or routine giving of a probiotic is not been allocated by the guidelines for the ISHRE and the ASI. Then coming down to the next half of my presentation is the evaluation of the male factors and their guidelines. We must know there is a disorders, maybe a psychological, maybe low testosterone concentration, low sperm count, and that contribute to the 35% of the infertile couples. So what we need to understand, again, come back to the history of her, like the history of his in the past. You need to give importance of the history for the evaluation of the infertile couple. That may be a medical history related to the mumps, maybe diabetes, orchiditis, prostate gland infection. Mainly, you need to give importance to the mumps, because if the person having the mumps in the childhood, it will reflect on the sperm parameters, and that will be at accountable cause for infertility. The surgical, definitely a correction of the hernia, undescended testes, or maybe a torsion, maybe the injury in the past has to be talked to the patient in detail. There may be allergic history, like you need to, after taking the history, the most important part, we all of us are forgetting what is the profession of that particular male patient. And the family history of diabetes also plays an important role, because if he or in his family there is a diabetes history, then he may have the diabetes in the future, and that could be one of the reasons for the infertility. After doing the history of the person, then we need to go with a detailed examination. What is the testicular volume? What is the testicles are, whether there is a single testicle or maybe both the testicles are descended down in the scrotal pouch, that has to be examined. Then examination of the glans penis, that will will rule out the hypospadiasis or maybe a cordially, and that needs to be assessed, and that will gives you a detailed examination of the male patients. The male partners, then definitely you need what always offer to the male partner is semen analysis. But when to do it, the semen analysis, what are the things needs to be taken into account? So that has to be talked to the patient, because just giving the semen sample randomly and generating the random analysis of the semen report will not be helpful as the fertility expert, because there has to have a gap of 3 to 4 days when he or comes down to you for the semen analysis. Secondly, you need to talk to him about the regular intercourse, whether he is achieving that particular because many of the time the psychological part is also one of the part of a infertility treatment, because he may be having a problem in erection, or maybe a penetration, or maybe there is a premature ejaculation that has to be talked in depth. Avoid, I think one should be talking to the patient first and then go to the examination, because there may be in a male partner, there is a much more problem as a psychosexual problems related to the orgasm, or maybe related to the erection. The evaluation of the male, as I told to you, has started with a detailed history. They may consider as a personal history, dietary history, because if he is obese, then it is a BMI, which makes a sense that BMI should be less than 24 in order to have a natural conception, because BMI itself is an indicator that he may have a low semen parameters, and then you need to ask him about the coital history, medical history, and the physical examination. Then he will go through. Then the normal things usually asked to all of us: how should we evaluate, and what are the guidelines? The guidelines in 2023 definitely tell us that if the patient of infertility comes down to you, after the detailed history and examination, you must do the semen analysis. One must know what is the semen analysis, what is the normal WHO semen analysis. It will depend upon the pH. Volume 1.5 is normal. Total motile count is 39 million. What is total motile count? Is the motile count is the number of sperms into a number of volume the patient ejaculated upon the number of percentage of a motile sperm. That will gives you TMSC, that is total motile sperm count, and that will helpful for us to understand and to know what type of treatment should be given, whether we should offer here IUI or IVF directly. That will tell by giving a TMSC count. Then we must know what is the concentration. The concentration by WHO, it should be more than 15 million. Motility more than 40%. That there is a 40% progressive motility. The morphology, definitely we all of us know that there may be a morphological defects, and that can be taken care by doing a CASA. And if it is more than 4% is a normal sperm count, will give this is a WHO normal guidelines. What are the recommendations? See, if you see on the right side, all are the strong recommendations that you should not advise anti-sperm antibodies. You should not advise DNA fragmentations if the WHO semen analysis reports are normal. And this why I put it this as a recommendations and the strong evidence, because we need to follow these guidelines. What are the guidelines says? You should not be doing anti-sperm antibodies. You should not be doing DNA fragmentation. You should not be doing chromatin condensation test. Sperm aneuploid screening, that is a Y chromosome or Y deletion. You should not be doing hormonal testing for all. HPV testing of the semen is not been recommended if the WHO semen parameters are normal. Microbiology testing of the semen is not been recommended if the WHO criteria is normal. And that's why, as a fertility expert, you must give importance for the semen analysis, and the semen analysis has to be done at the proper timing, at the proper lab, at the proper set, and you know what is the WHO criteria is. The azoospermia, if what is the evaluation, how to do it, and there is what is the recommendation. The recommendation is a straightforward. You need to do a clinical examination. You need to find out whether the testes are present or not. If the you come down to the testes are palpable, and you know the testes are not palpable. If the testes are palpable, then you need to do the FSH, and the FSH is high, or FSH may be low in your scenario. If you are going to have the FSH, which may be a normal, then what is the things you need to do? If the FSH is high, you know that it is a hypergonadotropic hypogonadism, and then the treatment remains that you need to do a karyotyping. In those karyotypings, what you will have to come to know whether it is a testicular failure or if it is a Klinefelter syndrome. If the FSH is low, that is a means that you are dealing with the hypogonadotropic hypogonadism, then you need to understand what test you will be doing. You will be giving a H2 axis is going to have the failure. If the FSH is normal, definitely it is a obstructive azoospermia. There are a number of videos in my Facebook also where we do a TESA and micro-TESA. If the testes are not palpable, then definitely you will go with the testicular biopsy first and then the TESA and TESA. If the testis is not palpable, see what is the volume of the testis. Volume of the testis is normal, then you will be doing a testosterone. If the testosterone is after giving the SCG injections, how much SCG should be given? Usually we give SCG 5000 twice a week along with the FSH and LH, that is HMG. We need to know the FSH is an indicator that FSH is on a higher side. Definitely this treatment will not be effective. This is only been effective where there is a testis which is non-palpable, and in those where there is a definitely a normal level of your FSH and LH, where you will give this SCG along with the HMG. The high testosterone usually comes down to the cryptorchism. Then there is no treatment for it. There is no testosterone which has been raised. It means that the patient is not having the testes at all, and he will not having any set done. So thank you for patience hearing the guidelines. I talk to all of you, and this is my Facebook group. All of you can join in for the happy learning. Thank you for the opportunity given to me. I'm happy to answer if there are any questions. Thank you.
Thank you, sir. You have covered very nicely with the guidelines, because when patient comes to us, we write left and right test. What should be done, what should not be done, we should know it properly. And one more thing I want to ask, what is the role of diagnostic hysterolaparoscopy? Like you have not covered, because we know it is a gold standard for the tubes and all. So what is
according to
your...
the ISHRE guidelines, first let me know what are the ISHRE guidelines. ISHRE guidelines not recommended to do all patients hysterolaparoscopy, because this is not the nowadays gold standard, because we have high-end investigations. Like if you wish to know the fibroids, you wish to know the tubes, there are different investigations. Hypocy you can do a 3D ultrasonography to evaluate the uterine factors. So definitely if everything is been normal and still the patient is not conceiving, then you can do a hysterolaparoscopy, wherein you will find it out the evidence of osteal evidence of the infection when you do a hysteroscopy. If you are doing a laparoscopy, then you will know peritubal adhesions or maybe a minimal endometriosis, but not the per se. The hysterolaparoscopy is the first or the gold standard for doing all the patients of infertility. Thank you.
Thank you. Thank you. So if it
Thank you, Dr.
infertility...
Ashish, sir.
Yeah.
Thank you so much. Yes, Anuradha, please continue.
If infertility more than 5 years, and then we can think of diagnostic hysterolaparoscopy.
If the infertility is more than 3 years, if the patient is having all the reports are normal, then you think of there is a peritoneal factors to evaluate, then and then only you can do a laparohysteroscopy, and not for all the infertility patients.
Thank
Then
you.
if a
Thank
good
you so much.
quality ultrasound is able to diagnose a lot of adhesions, even surface endometriosis and everything can be diagnosed by ultrasound. You just have to actually, with patience, look for it. Then you would not need it. And an ultrasound, a sono HSG will give you a lot of information.
Sometimes, madam, we confused with the unilateral block.
No, you will not be confused if you do a proper 3D and you do a contrast. You would never be confused.
There is a definitely, Dr. Anuradha, evidence, even if it is a unilateral block, the incidence of the conception is the same as that of the normal tubes. I just not mentioned that evidence, but evidence coming up.
That is true.
So unilateral
tube
block
is enough,
per se
right?
will not be evidence of doing a laparohysteroscopy.
Thank you. Thank you so much.
Thank you.
Thank you.
So we come to the end of this program. I would like to thank Hrishikesh Pai sir, Sonal ma'am, and Dr. Ashish Kale, also Dr. Anuradha, Dr. Sujaya, and Dr. Purvi. I also thank all my viewers who have persisted through this whole program and have given it the love and attention that we crave for. So thank you so much. See you again on another
you.
Wednesday.
Thank you, ma'am. Thank you so much for
Shubhratri.
giving this effort.
Thank you,
Thank you.
madam.